So next we're going to hear from Jonathan ZHANG. He's one of the neurosurgeons, and as you said, know neurosurgery / interventional neuroradiology is converging. And so he is one of the guys who's on the forefront of that. I would say that we heard Mike Mawad's name mentioned about Dyna CT. I think they were on the forefront of 3D reconstruction and imaging, and they're carrying on that legacy. Jonathan, thank you for coming.
Thank you, Alan. Good morning, everybody. My name is Jonathan ZHANG. I'm one of the neurosurgeons who is also a neuro-interventional surgeon, and have this privilege to come here this morning to talk about what we are doing in the exact opposite of the topic that the previous speaker was talking about. In the very, very small spaces, small blood vessel. The biggest blood vessel, where I always tell patients that we neurosurgeons work with, is probably about 3-4 millimeter. 5 millimeter is already the upper limits of what we do. But since these blood vessels supplies the blood to the brain and the spinal cord, and they have some extra importance. The advancement of the imaging technology really have revolutionized what the neuroscience, neurological technique we have done, and integrating different modalities of these imaging techniques, particularly CT, MRI scan, fluoroscopy, as well as some of the optics really has changed the way we can understand the disease process as well as treating these. I always joke with residents that the scientists or the physicians who have major contribution to CT, MRI scan, and angiography are the 3 persons all got Nobel Prize. None of the clinicians and all these other doctors actually can get close to the Nobel Prize. These are some of the examples that we can actually, in the workstations and harnessing the power of computings and to generating what we can do some of these things. These are the images you can see. This is a regular fluoroscopy image, while the 3D reconstruction, the volumetric rendering of the blood vessel can be projected onto the fluoroscopy. So during the surgery and the interventional procedures, that actually the roadmap is really the 3D, and the wire is, and microcatheter is going up to the basilar artery, going to the posterior cerebral artery with the aneurysm there. And with all of these things is seamlessly integrated together. We can incorporate the MRI scans in axial images with the 3D angiograms, fuse them together to help us to plan the surgery properly. This is the newest technology, which actually in the operating room we use quite a lot, using the, once we determine the trajectory on the workstation, the C-arm actually will turn into exactly the position, shoot a laser beam onto the patient's surface, and the direct line will be where the surface to the target, and we can directly puncture some of the most difficult lesions in the brain. Again, these are some of the pictures then that we can fuse patients' Dyna CT, MRI scan, angiogram from different injections, because the patient's skull is a fixed model, so the computer actually can easily to incorporate all these data sets together to form a much more complex and a more meaningful images, so that both during the planning as well as the treatment stage, we can understand the patient's anatomy, and in a way, we can reduce the radiation for the patient and increase the accuracy of these. So in a way, a lot of things we're doing nowadays is almost like playing video game. This is a couple of the examples I want to show. This is a patient in her late 70s, and over the last several months of time, she's progressively losing the capability of walking, and she became incontinent. She started to lose sensation in her lower extremity. So the astute neurologist was able to do the MRI scan, and the spinal cord here shows much more swollen with edema. More importantly is these flow voids in the subarachnoid space. And this is the MR angiography with high resolution showing the abnormal vasculature around the spinal cord. In the spinal angiogram, this is all the wiggly lines, but the selective injection into the left L1 pedicles, we actually see this rapid filling of this vessel. This is the contour of the spinal cord. And this the net of the vein is not supposed to be there. And this is a patient with a spinal dural arteriovenous fistula, a condition that only been understood for probably the last 10 to 15 years. This is the high resolution of the angiograms showing the fistula. Unfortunately, this fistula shares the same pedicle, this thing that the yellow arrow is pointing at. This is the posterior spinal artery that actually supplies the blood to the spinal cord. If we do embolization from this pedicle, there is a high chance the embolics will go into this, which actually will lead to damage to the spinal cord. So unfortunately, this thing cannot be treated endovascularly safely. So this, and we decided to proceed with surgery. And this is, again, the 3D angiograms of the spinal angiogram injections. This is the 3D reconstructions from the Dyna CT using diluted contrast, but more a slower spin over 20 seconds, reconstructed, showing precisely where the fistula starts and where the vein is, and coming out at the nerve root sleeves at the L1 pedicle. These are actually the surgical video and the what we call the endosigning. Okay, so this is under the surgical video. You see that the spinal cord, spinal nerve roots, and a seemingly harmless vein there. And when I injected the endosigning ring into the patient, you can actually see this thing lights up far faster than any of the normal blood vessel. This thing is that posterior spinal artery, the pesky things that's hijacking the patient's spinal cord at the same place. So they were carefully dissecting away under the microscope with the fluorescing to show us exactly which vessel, and this correlates with the patient's anatomy from the Dyna CT perfectly. And the postoperative, the angiograms showed the complete resolution of the fistula, while the posterior spinal arteries is well preserved. And very satisfyingly, this patient, after even 2 to 3 weeks of rehabilitation, is already able to walk. And hopefully she can make a good recovery from devastating conditions. And that many years ago, there's no treatment option. This is another patient that's showing, and actually came from Nebraska. She had 3 different embolizations in the university hospital there, and unable to treat this carotid cavernous fistula that's causing severe the visual symptoms. And if you look at the angiogram, these things, it's just the squiggly line everywhere, and a big high flow fistula is very difficult to understand exactly where the fistula's point is. Here, and with the help of our computer genius, and we were able to, using the Dyna CT, precisely seeing this is in the artery, the contrast is so bright. On the vein side, even though it should not show up, but the vein is diluted with the other unopacifyed blood, and we were able to see that the tiny connections between the blood vessel as well as the artery, the fistula's point is exactly this little pedicles there, and this is the patient's photographs of her eye from the severe fistula, and by doing this, and then combining the 3D angiograms, we were able to precisely delineate exactly of where it will be, and then using the same technology of the eye guide to precisely find out the projection and the location of the fistula. The microcatheter was able to find that particular spot seamlessly using the balloon to protect the carotid artery, and then putting in coil, onyx, liquid embolics, and at the end of the results, the entire fistula can be fixed in less than 30 minutes, and the patient actually have all her symptoms completely resolved, and just with one surgery with this interventional procedure. This is another way of we utilizing the different modalities into the angiographic suites. This is a patient who has, unfortunately, acute stroke from a left internal carotid artery embolic occlusions of the MCA. Using the state-of-the-art stent retriever and the suction, we were able to rapidly open up the blood vessel. And immediately we can use the Dyna CTs to do basically CT-like images. And here you can see this is not the contrast extravasation. This is the infarct of the brain tissues that basically all the contrast stays there. And then immediately after I finish the thrombectomy, I know this patient is going to be in trouble because of large established infarct already, because the blood does not flow into the dead tissue. And that's helping us to understand that we need to do surgery quickly to decompress. So without even going to the CT scan, we can make this kind of decisions utilizing what we have in the angiographic procedure, the tool. This is another patient who has an incredibly difficult aneurysm that in the back of the old days, endovascular treatment cannot be very effective because of the complex anatomy. If you look at the 3D angiograms, this aneurysm is almost like an octopus and incorporating all the major blood vessels at the basilar artery tip. This part is very, very deep. It's essentially in the geometric center of the brain. And nowadays, we were able to put in multiple stents from the basilar artery, basically reconstructing a Y-shaped stent construct through the same limb. And this is the Dyna CT, the 3D reconstructions, showing precisely how this was able to reconstruct the entire bifurcation, protecting the major posterior cerebral artery, the superior cerebellar artery, the basilar artery, and with these, a very, very extremely difficult aneurysm rendered into something very treatable. And this is the end results. You can see a clear line between the occluded aneurysm with the normal blood vessel, while the stent is protecting all these. And we actually were able to see how the stents are placed inside the blood vessel and see all the struts and how they reconstructed the entire bifurcation in an extremely difficult and sensitive area. And this is another final example. This is a patient who suffered acute subarachnoid hemorrhage from a very ugly-looking posterior communicating artery aneurysm. At the time, when I first trying to treat this patient endovascularly and to seal the aneurysm, the effort to try to acutely treating this was not very successful. The neck of this aneurysm was too wide. In fact, actually, this coil flew out of the aneurysm, so I actually have to use special devices to retrieve and pull the things out, fortunately. So I basically occluded this part of the tip of the aneurysm, which is the source of the hemorrhage. And that went very well, occluded. She actually made a good recovery from this. But 3 months later, when I follow up on her, and if you look at the immediate post-op treatment, and then 3 months, you can see the coil has been displaced and the new aneurysm is growing out. This is the shape of these. An aneurysm like these, again, I can put in coil and all these, but there is an important blood vessel coming off the neck of the aneurysm. If we put the coil there, there is a pretty good chance this will be harmed. So instead of these, what we do is putting in something called a flow diverter. These are like the cover stents the vascular surgeon uses, but they actually are much more flexible. We're able to be deployed in 027 microcatheter. And using these, with the metal porosity is so much dense to cover the blood vessel. However, all the perforating blood vessel will maintain their patency because of the drive in the tissue. And without putting in any coil or embolics in the actual aneurysm lumen, this is the Dyna CT showing exactly after the flow diverter device was inside the patient. You can see it's sort of like a metal jacket being placed inside the blood vessel with the aneurysm lumen still there. 6 months later, when I repeated the angiogram, you can see miraculously the aneurysm is completely gone. However, the important blood vessel still is patent through the flow diverter. So the endothelialization of these actually can proceed seamlessly while preserving all the important critical blood vessels and by occluding the aneurysm. And so these are some of the examples nowadays we're doing with neurosurgery and the interventional neuroradiology. You harnessing all these technology to helping us to see the finest small structures and hopefully improving the patient's outcome. Thank you so much.
Thank you.